Hi, okay, thank you very much for the opportunity to present this data. And I guess we don't need to discuss this bit. We've seen improving responses to ibrutinib plus venetoclax from 12 months and on to 24 months. Another component of the trial was to really try and look at some of the surrounding biology to see if we could find ways to better identify patients who are going to respond, but also maybe look at some what other options would be available for those who don't. In terms of sort of getting an idea of what's happening, one of the key questions is, can we use peripheral blood instead of bone marrow? Broadly speaking, we've seen already there's a good correlation, about approximately half a log difference. If we're looking at the key time points, 6 months and 12 months, what we're seeing is that those patients with 0.001, so between 10 to the 5 and 10 to the 4, only about half of those are MRD negative in the bone marrow, whereas those patients who are less than 1 in 10 to the 5, they're pretty much all MRD negative in the bone marrow. So we've been using that to identify maybe a guide to when is the appropriate time to do a bone marrow in the future. In terms of the sort of more biological aspects, we did have the opportunity to look at BCL2 BAX, MCL1 and BCLXL sequentially during treatment. Now, we had to focus the panel a little bit because there were 20 time points to measure and we couldn't do an extended panel on everything. We might have gambled on the wrong thing. We went for BCL2 and BAX at every time point and MCL1 and BCLXL only when there was a bone marrow being taken. But the results were quite interesting for BCL2 and BAX. The issue is that, of course, by the time you're taking a bone marrow, often people have completely cleared their disease already. So the more detailed data is only available for BCL2 and BAX. And you see a slight decrease on ibrutinib only, so after 8 weeks of ibrutinib in BCL2 expression, and then surprisingly, or to me anyway, counterintuitively maybe an increase in BCL2 expression after 4 weeks or so of venetoclax exposure. And a similar pattern for BAX. And there were differences according to the eventual 12 months of venetoclax, the response after 12 months of venetoclax. Those patterns were slightly different. So there's only a couple of patients, 4 patients here, who had 1% high levels of MRD after 12 months of combination. But they seemed to not recover BCL2 expression, and they had low BAX at baseline and during venetoclax. Whereas the patients who had the deep responses, the BCL2 substantially increased, and the BAX also did. So I think that there's possibly a signal that if you are already resistant to apoptosis, you're not so dependent on BCL2 for survival. These are the patients who might not respond so well to venetoclax, and that follows nicely with what Matt Davids was saying before. In terms of the limited MCL and BCLXL data that we've got, there does seem to be a slight signal that those patients who have a poorer MRD response have higher levels of those after exposure to venetoclax. I think a challenge, though, is if you're going to bring this into the laboratory, actually there are patients who respond very well who have that sort of baseline level of BAX, so it's quite difficult to. Here's an approach that will work in the diagnostic laboratory. And the other thing that we looked at was looking at the B-cell receptor pathway, phosphosic, that should be phospho-AKT, stimulated with immunoglobulin versus unstimulated during the course of the trial, and we would see as expected that there wasn't a great inhibition of SIC or AKT or ERK responsiveness after only 8 weeks of ibrutinib. What was surprising was that absolutely everything was shut down with venetoclax. So after only 4 weeks of exposure, you couldn't really see any ability to signal through the B-cell receptor pathway, even though the venetoclax wasn't essentially targeting that pathway. So the thing that was most useful was the MRD level. The biology is so variable in terms of the other things, but that response level was clear. If at 6 months of venetoclax exposure there was less than 0.01% disease, all of those patients had sustained that. Some of the patients with 0.01 to 0.01% disease had gone less than 1 in 10 to the 5, and variable patterns of response with those who had higher levels. And I think the point that John Seymour made is that you need to be looking at the kinetics. Some of those patients are going to have high that then goes down, and they'll probably be beneficial to continue treatment, whereas if the patients have low and then go up, those are the patients who are relapsing through the treatment. So I'd like to finish there. Thank you very much for the opportunity to present. I'd like to thank Peter, of course. I haven't put a picture of him because I think even he's had enough exposure for this presentation. So these are the people at the trials team in Birmingham who've done an extremely good job of helping us get all the data together. Thank you very much.